Start off with patient prep. It is so important that you remove all jewelry, earrings, dentures, any type of buttons or artifacts around the neck will also obscure the anatomy of the cervical vertebrae when we're radiographing. So be sure to ask the patient to remove everything basically from the waist up off, in the sense of they will have a gown, or normally you would just have the patient in their normal clothing. Unless there's buttons that might obscure some of the anatomy. Have all patients remove their earrings once again, necklaces, and also dentures, if you can. Explain and demonstrate the positions when possible. Respiration on all of the images that we take on the cervical are suspended. Just have the patient hold their breath. Now, the essential projections that we tend to do today are very limited. We do a lateral and an AP, and then also a DENS, or a 3-view cervical spine. One thing to note on the AP cervical includes C3 through C7, and the DENS, or the odontoid, when we take one specifically through the mouth, open mouth odontoid, is to look at C1 and C2. The reason for taking 2 APs is because of the fact that the mandible will obscure C1 and C2, no matter how you position that patient. If you extend their neck up, their mandible may be removed from C1, C2, but now the base of the skull is superimposed over C1, C2. So more of a natural, normal chin forward slightly for your AP to include 3 through 7, and then we'll go back always to get the open mouth odontoid. So here are the projections. Lateral, Grandi method, AP axial, AP open mouth for C1 and C2. If we're unable to get the DENS process or the odontoid process, we'll do a Fuchs method. And there is a lateral swimmers, and this is specifically for C7, T1 joint space. Now, it is a cervical thoracic region. There are 2 different methods that are within the swimmers. One would be the twining, and the other would be the pellet that we'll go over. So here's some additional C-spine projections that we will be doing that is important for you guys to know. We will do the obliques, and we can do the obliques either AP or PA, which means that the position of the patient in an AP would be an RPO or an LPO. For a PA, the patient's position would be RAO, right anterior oblique, or a left anterior oblique, LPO. 2 additional laterals. There's a neutral, which is part of our 3-view routine, but there's also flexion and extension. We're talking hyperflexion and hyperextension. To start off with, lateral. Usually performed on 8x10. 10x12 I think is a little bit better, so that we make sure that we include all of the opportunity of getting C7T1. 72 inches is your SID, and we're centered at C4. C4 is literally about at the level of the Adam's apple. The cervical spine in the lateral projection, when you take the width of the neck, lies towards the posterior third of the width of the neck. We align it with the mastoid tip, which is just posterior to the EAM or to the ear. It's a bony prominence that we have just directly posterior to our ear. We have the patient in a true lateral. Relax their shoulders down if possible. And once again, we will suspend the breathing. Do note that the top of your light is basically at the top of the ear attachment. Even though the cervical doesn't start there, it would start basically at about this region. This collimation is a little bit large. So this is what we should see. A good true lateral will show that all 7 vertebrae are present. So see 1, 2, 3, 4, 5, 6, 7, and you can also see the top of T1. For a complete C-spine, you are required to see the top of you are required to see the top of T1. Here we can see the vertebral prominence of C7 off the spinous process of 6, 5, 4, 3, 2, and 1, the anterior bodies, and we can see the joint space between the inferior and superior articular facets. And these are known as the Zygote Axial joints. Note how they all line up. So to be specific, here's cervical 5, 6, 7, and between 6 and 7, we see the inferior articular process and the superior articular process of 7, and where they meet is the Zygote Axial of C6, C7. Start being very specific on the exams or on the test, if you would. I need to know specifically which ones you are looking at. Hyperflexion and hyperextension are done normally after weeks or months after a patient has begun the healing process of their neck. It is to document the stability of their neck. So we are usually talking about fractures that had occurred or dislocations that might have occurred. But before we ever do any flexing of the neck forward or backwards, we have to make sure that a fracture had been ruled out well before. It's never part of your initial routine. Okay. Used to demonstrate absence of normal movement from trauma or diseases. So we're talking post. We're talking, like I said, weeks to months afterwards. So the image on your left would be extension. Image on the right would be flexion. The way to remember the difference between a flexion and extension, and to help you articulate it to your patients, is I ask the patient to flex their chin downwards, flex forward. So flexion of the chin downwards or forward would indicate a flexion, and if they raise their chin up, that would be extension. We're looking at the stability of all the vertebrae and how they align together. There have been, or there are documented cases where the vertebrae may slip forward because of the previous injuries that they had. In situations, the ZAs on the initial trauma have been separated or dislocated where the posterior portion of the inferior articular facet was locked in front of the superior, causing a wide gap between the disc and a separation, not a true ZA. So in those situations, you'll find a patient being in traction, lying on their back, They will have a halo around their head connected to weights to allow for the muscles to relax. And hopefully, upon relaxing, they will relocate back in the correct spots. So once again, flex forward, extend back. Lateral C-spine projections demonstrate the zygote joints, as I was explaining. And in the cases that it is an acute situation, acute trauma that comes in through the emergency room, patient presents on a backboard, it will be the first image that we take. The first view in a trauma situation would be the lateral. What we're looking for is to make sure that all the vertebrae are in alignment. Now I'm going to kick back a few here. What doctors are looking for is the alignment of the anterior border of all of the bodies of the vertebrae line up. In addition to, they're looking for any soft tissue swelling in between. Note how it's larger here around C6 compared to up here. There are ranges of soft tissue swelling that would indicate certain bony fractures that may have occurred. So in this situation, the patient's upright. We would never want to place a patient upright on their first image, even if it is a lateral that we're trying to get. So we do a cross-table lateral. This way, the patient's the head is usually not rotated. The patient will have a Philly collar on, so it's demobilized to protect the neck. Because any movement that we do, or if we had the patient rise up so that we can do an upright lateral, could cause more damage to the patient. So we always do a cross-table lateral. The centering's the same size cassette. The centering's at C4. You try to get the 72 inches, but in a trauma room, good luck. More than likely, it's going to be 50 to 60 inches. Therefore, your normal technique that you would have used within the X-ray room will have to be compensated due to the fact that you have a shorter SID and possibly a different grid. These are the things you have to take in consideration when doing a cross-table lateral and manipulating your technique. Lateral swimmers. These are usually performed upright, can be performed on the table. It is specifically to see the joint space of C7, T1. So when C7 is not well demonstrated on the lateral projection, we will do a swimmers. Could be the fact that the patient has very broad shoulders and their shoulders are up because of the trauma that they sustained. Maybe it was a whiplash, but their muscles are starting to tighten up and they're unable to relax their shoulders down. So in these situations, we'll do a swimmers. Now, a swimmers upright is performed at 40 inches. You position the patient on the lateral, raise the arm closest to the IR above their head or across the forearm across the top of their head. You relax the shoulder, the further shoulder down. We're centered at C7T1, and oftentimes we will throw a 3 to 5 degree caudal angulation through that region. What it allows us to do is separate the two shoulders that are in alignment. So now we're coming down at an angle through it. So this is specifically of the region of C7T1. You can see where it's labeled cervical 6, This would be the body of 7, and here's T1. The bone coming down and around would be the clavicle. Here's the other clavicle. But I'm going to throw out a warning here. Note how they're assuming that this is T1, and they're doing that because this is a rib coming off. But how do you know that is cervical 7? How do you know that is cervical 6? It's not documented that this is 5, 4, and we can't see 3, 2, or 1, or maybe somewhere the patient has an extra vertebrae. Going back an image, note how they have it basically at the base of the mastoid tip. I oftentimes will go for the EAM down to make assure myself that I included all of the cervical vertebrae, including the top of thoracic vertebrae 1. So if you collimate down just specifically for C7T1, we don't know, or you don't know, what vertebrae you're actually looking at. Could it be this is 8 and this is T1? This is 7 and T1? Especially when you collimate down to a smaller area, you are losing the ability for the radiologist to count all 7 vertebrae or 8 to document where that interspace between the cervical and thorax, where it lies. So extend, open your collimator a little bit more to include all of the cervical vertebrae. I think it's just a good process to get involved with. Let's see. Oh, look, you can actually see the ZAs there. And that would be the ZA of 3, 4, or I mean 4, 5. This is 5, 6. Now for the AP. APs are done at 40 inches, 8 by 10. We will throw a 15 to 20 degree cephalic angulation centered at C4. Oftentimes we will try to get the occlusal plane perpendicular to the IR. The occlusal plane is the top margin of the teeth. So if with the teeth being aligned, the bottom surface of the top teeth is called the occlusal plane. We will bring the chin up or down so that it is perpendicular to the IR. Do note that they're centered once again at C4 or at the Adam's apple. And because of the mandible, as I explained earlier, we will never be able to see C1 or C2. Collimation, you can collimate just to the skin line on both sides. Note the marker. I tend to put my marker a little bit higher. That's just me personally. And this is what we should see. We can see the rib, first rib coming off, so that would be T1, 7, 6, 5, 4, 3. Note how 2 is being obscured and widened out because of the densities of the mandible and the occipital bone. We can also see the intervertebral disc space between 5 and 6. Here's the body of 5. Here's the body of 6. In between the two would be the intervertebral disc. The oval teardrops that are coming down in the mid-sagittal plane. There's one there. There would be a long one there. Another one, all the way down, are the spinous processes. You can even see the air-filled trachea. Here is a variation, just to know, and maybe I should have put it after doing the odontoid, to look at C1 and C2. What we're looking at here is the body of two, the dens process, the lateral masses, the joint space between 1 and 2. But do note how the mandible is blurred out. It is literally blurred out because of what commands we provide the patient. We ask the patient to wag their jaw, move their jaw up and down. That little bit of movement with a longer exposure time will blur out the mandible, allowing us to see C1 and C2. So it's called the wagging jaw. Normally we'll do an AP open mouth. Double check here, I believe, and I may be incorrect, or this is incorrect, I should say. It should be 30 inches. So an AP open mouth, the IR would be an 8 by 10. SID is 30 inches. Sorry for that mistake there. CR, midpoint of the mouth, and how we position is that we align the upper occlusal, upper incisors and mastoid tip perpendicular to the IR. Another way of looking at it is if the occlusal plane is parallel to the mastoid tip and perpendicular to the IR, the alignment of the tilt of the head is correct. It's a very difficult one to get due to the fact that there are many different shapes of the skull. So what we're looking at here, we have the patient open their mouth. We align the occlusal upper incisors, or I say the occlusal plane, to the mastoid tip, which would be posterior to the ear. Open up their mouth. Where their lips join on either side is where the central beam should be coming down through, and it's a perpendicular beam. So this is a really good AP open mouth. Note the dens process centered in the mid-sagittal plane. We can see the body of C2 here. Also the lateral masses of C1, and that they're aligned on each side, that they're not shifted over left or right, and that the fillings that this patient had or has do not obscure the region of interest, which would be the joint space and also the dens. Note how the occlusal plane of the maxilla and the front teeth are just barely above the tip of the dens. And this other line here coming across and around is the base of the occipital bone. So we're trying to get them in line, the occlusal surface of the teeth and the occipital, so that the occipital doesn't come down as you raise your chin up, or if they tuck their chin down, now the front teeth are now obscuring the dens. And then in addition, luckily enough, this patient doesn't have a mouthful of metal obscuring the dens or the lateral masses. So this is a really good AP odontoid. Now, there are times, as I explained, that this patient doesn't have a lot of fillings along the front teeth, but there are times where they do, or they're unable to raise their chin up enough or down enough to align the surfaces that we may have to do an AP dens. Now, a AP dens, the method is known as a Fuchs. A Fuchs method is specifically looking at the dens process or the odontoid. It is not looking at the lateral masses or the joint space between C1 and C2. It is specifically looking at the dens process within the foramen magnum of the occipital bone. Now do note, Fuchs method is contraindicated if there is a cervical fracture or there's some type of disease that might be going on, so you don't want to hyperextend their chin up. So for an AP Fuchs, 8 by 10, I believe it is 40 inches, we would have the patient extend their chin up as high as possible, perpendicular beam coming down directly at the just inferior to the mental point of the mandible. So position, tip of chin, and mastoid tip are vertical to the IR, collimate to about a 5 by 5, suspend the respiration, and what you should see is the foramen magnum, the dens process within the foramen magnum. Superior to that, this line, this arch here, is the rim of the mandible. So by extending the chin up, we're raising the chin above the foramen magnum, which by raising our chin up, we're actually pushing our occipital bone inferiorly or rotating it inferiorly, allowing us to be able to see the dens process, the odontoid, within the foramen magnum. Okay, moving on to the obliques, AP axial. Remember, AP would be as if they're facing you. Oblique. We are specifically for the obliques looking for the intervertebral foramina. In the case of doing an AP oblique, meaning the patient is in a position of a LPO or an RPO, we are looking at the foramina furthest from the IR. Both sides are examined. We perform bilateral obliques. So if you learn your AP obliques in an AP projection, the patient will be in an LPO for one picture and also a RPO for the next. Remember, we're looking at the foraminus furthest away from. So note, there will be a little bit of magnification in the foraminus, in the side of the foraminus that we're looking at. So here we have the patient in an LPO, body's turned slightly to about 45 degrees. We have a angulation of the CR from 15 to 20 degrees. Cephalically, we bring the chin away slightly from, or have the patient extend their chin out a little bit. And we once again center at the level of C4. All cervicals, AP, lateral, and obliques are centered at C4. In this position, in this LPO, we are looking at the right intervertebral foraminus along the right side of the patient. Do note the blue marker on the left side indicates the left. And this is what we should see. We should see all the vertebrae and the foraminus open, meaning that the patient was obliqued roughly at 45 or 45, and that they're not being closed off because that you under or over rotated them. Also, by extending the jaw forward or the mandible forward, we're getting the ramus of the mandible out of the foraminus, out of being superimposed over the cervical vertebrae. PA, axial obliques, the intervertebral foraminas that we are viewing are the side closest. So in a PA, we do everything opposite of an AP. We oblique the patient 45 degrees. We have a 15 to 20 degree caudal angulation. And now we're looking at the foraminas closest to the IR. So a little bit steep. That looks more like what, 70, 80 degrees on the amount of rotation. So we would want the patient rotated roughly at 45. The chin would be extended out, 15 to 20 degree caudal angulation. And in the PA projection, we're looking at the right side, the side closest to the IR. And do note, the obliques can be done at 72 inches. This change came about 3 years ago. We used to do about 45. You're going to find that a lot of technologists will not put the 15 to 20 degree angle on it, whether done AP or PA, and they just shoot it horizontal with a horizontal beam. But Merrill's states that it should be a 15 to 20 degree angle on the tube, whether cephalic or caudal, based upon the position that you put the patient in. So we are looking at the foraminas on the right side. So in a PA axial, what's the position of the patient? RAO, side closest to. Okay, leave you with this last image.